muting yourselves, just so I don't get a lot of background noise. I would appreciate that. Thank you very much. So I'm speaking to you today as a settler on the traditional territories of the Haudenosaunee Confederacy and the Anishinaabe Nation. I'm very grateful to be able to live, learn, and play on these lands. Now I'm going to figure out how to share my screen and make sure that everything's in working order. Okay, can everyone hear me okay and the slides are visible? I can't see anyone, so if someone just unmutes and lets me know everything's running smoothly, that would be great.
Yeah,
Thank
looks
you.
good.
Okay, thank you. It's when you're in presenter mode, you don't see anyone else, so it's difficult to talk to a blank screen. So I appreciate your sense of humor and patience with me. So I have a few things that I was hoping to chat with you today, and I really wanted to leave lots of time for dialogue because I think this is an area that's evolving and is very complicated and really impacts our day-to-day work. And so I would be grateful also for the opportunity to learn from you and to have lots of time for questions and dialogue. So in terms of conflicts of interest and disclosures, I have no financial supports to declare. I did serve as an expert witness to the House of Commons and the Senate committees that were studying Bill C-7, which is the expanded MAID legislation, which we'll be reviewing today. And I also serve as an advisor to the Vulnerable Person Standard. If you're not familiar with the Vulnerable Person Standard, you can check out their website, but it's an internationally recognized group of ethicists, lawyers, medical experts, and human rights advocates that make recommendations for safeguards that are needed to protect vulnerable people from harm in regimes of assisted death. So what I was hoping to do today was to kind of give you some background on the history of the Canadian legislation for medical assistance in dying. Again, sorry, I'll just ask you to mute. Thank you. And then the changes that we're seeing under Bill C-7, because I think the background context of where we got to with Bill C-14 and then now where we are with Bill C-7 really informs some of the concerns that are coming forward today and how we navigate this new landscape. I was hoping to discuss some of the impacts on expanded MAID, both our clinical practice, and of course, I'm not a spiritual health expert, so I look to you for your wisdom on that. But in terms of medicine, I can speak to, and the impact on vulnerable populations who themselves have been speaking up about their concerns about the new legislation on their lives. And to spend a little bit of time exploring some of the impacts of the new MAID regime on healthcare professionals themselves, such as conscience, moral distress, and disenfranchised grief.
Mm-hmm.
So first of all, let's just start with some definitions. So what is medical assistance in dying? So MAID, as it's otherwise known as, is actually the act of intentionally causing death through the administration of a lethal dose of drug. So that drug can either be administered by the person, him or herself, which is known as assisted suicide. In that case, the doctor or the nurse practitioner in Canada writes the prescription, but the person takes the drug themselves. And euthanasia, as it's known in the rest of the world, and so I will sometimes use the term euthanasia, and not to be provocative, but just to be factual, because in other countries where this is legalized, where a doctor or nurse practitioner administers the lethal dose of drug, that is the name the rest of the world uses. So I do not mean any offense if I use the term euthanasia, but it will be in reference to other studies from the Netherlands, for example, in Belgium, where that is the name that this is called. Of interest is that almost all of the cases of medical assistance in dying in Canada are clinician administered of the lethal dose of drugs, so rather than assisted suicide. For example, in 2019, there was about 6,000 cases of MAID, and only 7 of those were individuals who chose to take the lethal dose of drugs themselves. Why do people ask for medical assistance in dying? So the Canadian literature is consistent with what we've seen internationally in other countries who have legalized both euthanasia and assisted suicide. And the primary reason is existential suffering. It's not due to uncontrolled physical symptoms, as the public has been led to believe through stories in the popular media and on social media. There are no examples of cases of of MAID that are due to uncontrolled pain, for example. It's really around loss of control and autonomy, fear of being a burden to others, fear of having pain or dying with discomfort, and a loss of ability to be independent and enjoy life. How are MAID and palliative care related? And this is my only slide really on MAID and palliative care, even though that's my area of expertise, because that's an entire talk in and of itself. But I just wanted to lay some of the framework around why I am well suited to speak on this topic. So as a palliative care physician, we have very significant expertise developed over about 50 decades of specialist practice in palliative medicine, really understanding and addressing desire to die in persons who are facing the end of their lives or the possibility of the end of their lives. We have navigated requests for hastened death since our specialty began. We've become experts in addressing suffering and existential distress, including focusing on enhancing quality of life and living while dying. Lots of tools have been developed and we still have a long way to go, but around dignity conserving care is a big focus of the work that we do. And really, we've been on the forefront of medical assistance in dying in Canada since its legalization, just due to the nature of the original legislation, which required someone to have a reasonably foreseeable death. So we very commonly have to navigate requests for desire to die, which may or may not mean that a person wants medical assistance in dying. Palliative care and MAID are distinct. Palliative care itself does not hasten death. That's part of the core foundational philosophy of care, that we don't end life. But there's been some confusion between the two, in part because of the euphemistic language that's used. Medical assistance in dying has been called end-of-life care, but in fact, it's ending of life. It's an ending of life procedure or a life-ending procedure. And now, as you'll see with the C7 legislation, it goes well beyond anyone who is approaching the end of their life, and is open to anyone with a chronic illness, disease, or disability. Palliative care was itself seen as a safeguard by the Supreme Court of Canada and was built into the legislation through the process of informed consent, that people would have to be informed about palliative care before they could choose MAID, which we'll talk about a little bit later, whether that's true informed consent or not. But I've been involved in the Canadian Society of Palliative Care Physicians for the past 8 years on the board of directors, and in my role as I did a 4-year term in the president role, which just finished last year. I was directly involved in the consultations on the MAID legislation, including most recently C7. As I mentioned, I was an expert witness for both the House of Commons and the Senate studying the bill. And we've been involved in developing and advising on safeguards needed to reduce harm and protect vulnerable people. So let's just walk through how do we get to where we are today with the Canadian legislation on MAID? So prior to 2015, there was a complete prohibition through the Criminal Code of Canada on causing the death of another person through homicide or counseling or aiding suicide. In 2015, in the landmark case Carter versus Canada, the Supreme Court of Canada struck down that criminal prohibition and made an exemption for the purposes of medical assistance in dying for people approaching the end of their life who had unbearable suffering. What followed then was the government developed legislation to provide guidance on regulations around how medical assistance in dying would be done in Canada, and that is Bill C-14, which we'll review shortly. Following that, there were many individual court challenges at provincial levels on exceptional cases where, sorry, Heather, I'll just get you to mute your microphone if you don't mind. Thank you. There are many individual court challenges on people who felt that they should also be eligible for MAID, but only one that in Quebec that struck down the reasonably foreseeable death criterion as being unconstitutional. The other cases gave like individual permissions for them to go ahead and have MAID. But this landmark case, Truchon and Gladue in the Quebec court, mandated that the government change the legislation, or in Quebec, they would have the prohibition on outside of the reasonably foreseeable death context lifted. And so interestingly, this is the first time I think in Canadian history that a provincial lower court ruling has changed federal legislation. In the past, it would be typically something that the government would appeal. It didn't even go up to the superior or the higher court in Quebec, the appeals court or the Supreme Court, despite many outcries from the disability community about what this ruling would mean for them. So there were 3 extensions given. The original ruling gave the court gave the government 6 months to change the legislation to remove the reasonably foreseeable death criterion. And basically a year and a half later, sorry guys, just a reminder to mute. It's really hard to pay attention with the background noise, sorry. Bill C7 was enacted in March 2021. There, in addition, as you'll see, to removing the reasonably foreseeable death criterion, they also added a sunset clause on the prohibition for providing medical assistance in dying for mental illness as a sole condition. And that means that the prohibition on mental illness as a sole condition will be lifted in 2 years. So after March 17th, 2023, that will no longer be prohibited. And currently, we have ongoing study. We have a formal special joint parliamentary committee on medical assistance in dying currently meeting even this week in Parliament. That is looking at further expansion of the legislation to include mature minors and advanced directives. And the Minister of Justice has been very clear that this is a planned expansion, and they're going to be looking at doing these expansions in a phased approach. So that's what the study will involve, like what will that look like? So since legalization, we've had over 21,000 MAID deaths by the end of 2020 in Canada. In the first year in 2016, we had just over 1,000. And then by 2020, we had about 7,600. So a 648% increase in the number of cases over 5 years. Just in last year, 2020 to 2019, that it was an over a 30% increase in the number of cases. So it accounts right now for about 2.5% of all deaths, with some regional variation. So for example, in some places in British Columbia, there have been reports of the percentage of deaths reaching as high as 6 to 7%. And there hasn't been further study into looking at what are the factors involved in that regional variation, but hopefully the government will be looking into that. Under C14, so our original MAID legislation that was enacted in 2016 that we just reviewed, these are the eligibility criteria. So you obviously have to be eligible for publicly funded health services in Canada. You have to be at least 18 years of age and able to make your own healthcare decisions. You must have a grievous and irremediable medical condition, which includes an illness, disease, or disability, a death that is reasonably foreseeable. Your request must be voluntary and you must provide informed consent. I won't have time to go into it today, but these terms that are highlighted in bold, grievous and irremediable and reasonably foreseeable, did prove to be a source of confusion within the medical assistance in dying provider community, because there is no clear language around what does grievous and irremediable mean, what does reasonably foreseeable death mean. There weren't any specific time parameters put around that. For example, in other places like Oregon, assisted suicide death has to be expected within 6 months. But that wasn't the case in Canada, and there were many individual court challenges throughout those leading up to C7 in 2021, where judges ruled that a person's death could be reasonably foreseeable based on age alone, for example. So there was a case in Ontario, patient AB, who had osteoarthritis and was deemed eligible based on age alone. So it has caused a lot of confusion, and I think some of the exemptions through the courts were due to these language discrepancies. So the Supreme Court of Canada, when they made their Carter case ruling, described how they felt that a robust system of safeguards would need to be put in place to prevent errors and protect vulnerable persons. And then through the C14 legislation, they came up with a system that's described in the schematic here that I've put for you today. So there was certain eligibility criteria, which we've just reviewed. There were 2 independent medical assistants in dying practitioner assessors who would confer eligibility, that the person requesting meets the eligibility criteria, and that 2 independent witnesses would verify that the person making the written request was doing so freely, that the person had capacity, meaning understood what they're asking for and is able to make their own decisions, both at the time of the written request for medical assistance in dying, as well as at the time the procedure was administered. There is a 10-day reflection period required from the time of the request to the time of the procedure in order to allow people time to change their minds. Important to note that there were allowances already built into the C14 legislation for that 10-day waiting period to be waived if the person was at risk of imminent loss of capacity or imminent death. And then the last one was that they would be providing informed consent, and the legislation requires that person requesting medical assistance in dying be informed, meaning be aware of all of their other options and specifically including palliative care. But there's no requirement for those options to be necessarily available or accessible or to have been tried, which we'll come back to later. So what's interesting is that through the C14 legislation, medical assistance in dying was deemed an essential service under the Canada Health Act, which meant that it must be funded and available to Canadians kind of coast to coast. So every province and territory devoted resources to allow people to get assessments and navigate requests and get made if they wanted it. But no similar right has been deemed through the Canada Health Act to important supports that people need to live, including things that are considered safeguards for MAID, including palliative care, home care, disability supports. We know that in Canada, palliative care is severely under-resourced. Less than 30% of Canadians have access to palliative care, yet over 90% of deaths would benefit from it. The Canadian Institutes of Health Information, in their most recent report, which is now a few years old, showed that less than 15% of patients in Ontario received palliative home care services in their last year of life. We don't have good statistics on how many persons living with disabilities have access to disability supports. But during the C7 debates, the Federal Minister for Disability Inclusion, Carla Qualtrough, said to the Justice Committee of the House of Parliament that in some parts of Canada, it is easier to get access to MAID than it is a wheelchair, which speaks to some of the limited access that persons with disabilities have to be able to get the supports they need for living. We see concern coming forward around this aspect of MAID being an essential service and basically a right under the Canada Healthcare Act, but palliative care and other supports are not. And I just want to point out this recent article in an editorial in The Conversation by Dr. Janice Miyazaki. Dr. Miyazaki is the head of the Movement Disorders program at the University of Alberta. So she works with people that have Parkinson's disease and other movement disorders, and she's a neurologist who also does some palliative care. And she also was quite concerned that palliative care, which can benefit many of her patients, isn't often accessible or easy to navigate. How to coordinate the care, how to get access to it is not as streamlined as being able to access medical assistance in dying. So I recommend, and I'm happy to send the links. This is a really great read, but I want to share one excerpt from her paper with you, an example she gave about a recent patient encounter. John started his first appointment in the neuropalliative care clinic with, "I want to talk about MAID." In our clinic, his request for medical assistance in dying is common. As legislated by the government, I referred him to the MAID navigator. I had one request, that John wait to make his MAID decision until after seeing a community palliative care physician. At his next appointment, John informed us he had withdrawn his MAID request because his primary symptom, pain, was now well controlled after our suggestions and those of the palliative care doctor. John lived for 2 more years, during which time he became closer with his daughter and continued to enjoy the company of his siblings. And that is a common experience for certain in my practice. And I could give multiple similar examples of people who came in expressing a desire to die, now often manifested as a request for MAID when it might not be that's what the person wants. And so there's definitely a concern within the not just the palliative care community, but the medical community, that MAID is might become the default when we haven't taken the time to explore, or the time needed to provide the care that people really want. Dr. Romaine Gallagher, in the article below, Hastened Death Due to Disease Burden Distress That Has Not Received Timely Quality of Palliative Care as a Medical Error. She's a professor in palliative medicine at the University of British Columbia. Near the end of her career, she's just joined the board of the Canadian Society of Palliative Care Physicians. She's done some quite detailed studies looking at the Health Canada reports on MAID, and especially the first annual report, which came out last year. And she shows how the lack of access to quality palliative care should be considered a medical error, that some patients, not all patients, who get MAID may have unmet palliative care needs, and they may have changed their minds, much like John in Dr. Miyazaki's case, had they had access to the care that they needed. So she goes on into detail, and I won't go too far into it, but in the Health Canada report, there's 16% of people who got MAID had access to palliative care for less than 2 weeks prior to them terminating their lives. And we know that by that point, people could have had many months of unnecessary suffering or poorly controlled symptoms, that we have shown that earlier interventions of palliative care help people live better, live longer, have better control of symptoms, and better satisfaction with care. And another 16% of those people who got MAID had no palliative care at all. So that's about a third of people who got MAID that had either no access to palliative care or limited access to palliative care. And how many of those would have changed their minds, like John? Dr. Gallagher says this should be considered a failure of our system, as many of these people may have suffering for months without access to high quality palliative care. So let's now look at the changes under Bill C7. So we talked already that the Truchon and Gladue ruling led to the removal of the reasonably foreseeable death criterion, which was ambiguous to begin with. So what happened under C7 is that we've now created 2 tracks for eligibility for medical assistance in dying. And the timelines and the requirements and the safeguards are different for the 2 tracks. So track 1 is basically the C14 legislation, those that have a reasonably foreseeable death. However, they have changed the safeguards that we just reviewed. So there are changes to the safeguards, and we'll go through those. Track 2 is for those that do not have a reasonably foreseeable death, and that can apply to anyone with a chronic illness, condition, or disability. Mental health can be the reason for the request for MAID, but not the sole condition. And as we'll talk about, often people living with disabilities and living with chronic illness have a comorbid mental health condition that might be what's prompting their request for MAID. And as we talked about, the sunset clause lifts the prohibition on mental illness as a sole diagnosis for 2 years, so after March 17th, 2023. So in track 1, the changes to the safeguards include, now you don't need to have 2 witnesses who verify that you're making the request freely. It can be 1 witness, and that person can now be a paid healthcare worker. Interestingly, you need 2 witnesses to sign your will. There is the removal of the 10-day reflection period. So theoretically, you could request MAID on the same day that it could be administered. So there's no requirement for that 10 days. And a lot of the push for this was that, there was concern that people were losing capacity and not getting access to MAID. But in fact, there was already an ability to waive the 10 days if you were going to lose capacity. So that was quite contentious during the C7 debate in terms of why that was being removed, when there's actually lots of evidence that people do change their minds. So in the Health Canada first annual report that I've been referencing, which came out in 2020, in 2019, 263 people out of the almost 6,000 people who got MAID requested MAID change their minds. So that's still 200 people who changed their minds who now may not have the opportunity to do that with removal of the 10-day waiting period. We don't know, of course. We can only worry that there might be people who they had some time for reflection may change their minds. The waiver of final consent. So what that means is that you no longer have to have capacity at the time of administration of the lethal dose of drugs. So at the time of the MAID procedure, you don't have to reaffirm that that's what you want. So it is actually a form of a limited advance directive. And so there's certainly some lots of concern around that. There's no opportunity then to change your mind. You've entered into a written agreement with the MAID provider that in a certain time frame, whether or not you have capacity or not, you would go ahead with the MAID procedure. So this is the updated schematic of what I showed you earlier, which shows the changes through C7 on the safeguards put in place for people with a reasonably foreseeable death. So if you start with the eligibility criteria, obviously that requirement for reasonably foreseeable death has been removed. The question around the assessors, I don't have time to go into detail about that today, but there have been some concerns raised that the assessors might not be fully independent because they come from a small community of practice, and they can see each other's consults, and sometimes the second assessment is done on the phone after speaking to the first assessor. So there have been some concerns expressed through the parliamentary process that there needs to be some more robust mechanisms to ensure the independent nature. There are no longer two independent witnesses, as we've discussed, and no longer have to have capacity maintained, and the 10-day reflection period has been removed. The other area that we just touched on is around informed consent. And that is that if you don't have access to supports needed to live, for example, if you have a disability and you don't have a wheelchair, as Minister Coulter said, or as we've seen in Dr. Miyazaki's example of John, what if you didn't have access to palliative care? Is that really informed consent if there's no requirement that the services or supports you need to address your suffering and to live is accessible and available? And we know that many of those, because they're not deemed essential services, like MAID is under the Canada Healthcare Act, many people don't have access, especially people in rural regions, for example, to services like palliative care that might help them live. So the track 2, so now we're on to the folks who do not have a reasonably foreseeable death. So these are people that have either serious incurable illness, disease, or disability. The suffering can be physical or psychological. Their legislation does require they have an advanced state of decline. There has to be 2 MAID assessors still, and one of those, so this is an additional safeguard, has to have expertise in the underlying condition that's leading to the MAID request. And if they don't, they have to consult with a physician or a nurse practitioner who does have that expertise, but there's no requirement for direct involvement of the specialist or the expert with the patient. So they don't have to see the patient, they just have to speak to the MAID assessor. And during the C7 debates, it was made clear that in most cases, the MAID assessors themselves will be able to have the expertise needed because there's no requirement that it has to be a specialist. That was one of the safeguards that was changed. Originally, it was that you had to have a specialist, like someone with training and credentialing in that certain condition, for example, Parkinson's disease, someone like Dr. Miyazaki. But now they just have to have expertise, which many physicians with more general training could feel they have the expertise, and there's no stipulation around any further requirements about what does expertise mean, and definitely some concerns that if the expert hasn't seen the patient directly, they might not have the full picture. There needs to be 90-day period from the end of the first MAID assessment until MAID can be provided. That 90 days can also be waived if there's imminent loss of capacity or if there's a risk of loss of capacity during that period. And again, they have to have been informed and offered other treatment options, but not necessarily that they're accessible or that they've tried them. The 90 days itself is quite concerning because it can take many years sometimes to see someone who might be a specialist in your condition. So for example, someone living with chronic pain, it can take well over a year to get access to a chronic pain expert who may be able to help you with your condition. The same for psychiatry. So the wait time for psychiatry can be as much as like 18 to 24 months. And so that was definitely a concern that came up during the C7 debates as well, that 90 days is not sufficient time when it takes sometimes many years to be able to see someone who can help you address your underlying illness. So we've talked about this a little bit, that now MAID is available to anyone that has subjective intolerable suffering due to chronic disease, disability, or mental illness as a comorbid condition. And beyond March 17th, 2023, you'll be able to have mental illness as a sole underlying condition. I wanted to just give some examples of the types of chronic diseases that we're talking about. I think it can be quite eye-opening for us when we start to think about, really, this is pretty much anyone. There are very few people that have mental illness as a sole diagnosis, perhaps some very young people, but chronic diseases can be anything from types of arthritis to epilepsy, fibromyalgia, chronic pain, any type of lung, kidney, or heart disease, diabetes. These would all be examples of irremediable illnesses. And remember that the definition in the legislation does not require you to have treatment. So it could be something that could be easily treatable with standard of medical therapy, but the person is allowed to say that they don't want that treatment. And so by not having the treatment, it can become irremediable. I hope that makes sense. So it may be that something that could be reversed or improved, but that it goes on to cause progressive decline as required in the legislation because the person chooses not to receive treatment. And in the Supreme Court of Canada's ruling in the Carter case, they did recognize that right of a person to forgo medical care, but it was in the context of people with a progressive life-limiting illness who were nearing the end of their natural lives. And it would make sense at some point, right? We talk about that in advanced care planning. At some point, the burden of a treatment may outweigh its benefits. But what we're talking about in this case is people who have many decades potentially left to live that have treatable illnesses who could now say, I don't want my depression treated, for example, and that would make them then eligible for MAID under the way this legislation is written. The definition of disability used in Bill C7 is also very broad and leaves lots of room for concern in the disability community. So it refers to any physical, mental, intellectual, cognitive, learning, communication, or sensory impairment, or a functional limitation. And these can be permanent, temporary, or episodic in nature. So a broken hip, for example, could be considered something temporary because it can be fixed, but it could be a reason that someone might request MAID. Anything that hinders a person's full and equal participation in society. What's also very apparent is that there is a big overlay with comorbid mental illness, including depression and suicidality in chronic illness. And so I'll just reference a couple of studies that show the increased rates of suicidality, suicidal ideation, people with acute life-threatening illnesses such as traumatic brain injury, heart attacks, myocardial infarction, spinal cord injury. The suicide rate, for example, in spinal cord injury is 5 times higher than that of the general population. Head trauma is associated with twice the risk of suicide as a general population. Epilepsy, 5 times the suicide risk. Chronic pain, 3 times the suicide risk. Suicidality is often less related to their physical limitations, but often due to lack of social support, employment, and relationship opportunities for people living with disability. This study here by Kishi was it was a US study in Baltimore, and it followed a group of almost 500 patients with traumatic brain injury, stroke, or spinal cord compression. And over 7% of all of those folks they saw in their hospital system had either an active suicidal plan or had already attempted suicide. And they were 7 times more likely to have had a depressive disorder and almost 3 times more likely to have had a family history of psychiatry, family history, psychiatric history. Many of those patients seen in follow-up up to 2 years later, their suicidal ideations had resolved, and they rated their quality of life as equal to somebody without a disability from some of these physical illnesses. And really, they showed that the peak of suicidal ideation in this population after a life-altering diagnosis like spinal cord injury was around 3 months. And so, the physiatry experts in Canada have been quite concerned that the 90-day waiting period is not sufficient when that actually coincides with the peak time of suicidality in many of these types of illnesses. And there's a recent study that actually just came out a few weeks ago from Dr. Chakova and Dr. Ethans, Canadian physiatry experts, who I heard had the privilege of hearing present. And they looked at the lived perspective after spinal cord injury in a qualitative study of desire to die and desire to live, specifically around MAID. And over 50% of the spinal cord injury persons that had spinal cord injury that they interviewed had suicidal ideation within the first 2 years of their spinal cord injury, and that they themselves felt that if they had been offered MAID, they would have taken it, and that they wouldn't have been able to make an informed decision about it in that early time because they were so suicidal and depressed. But that through community supports, peer mentoring, and programs of rehabilitation with like equipment and supports needed to live, they were able to reintegrate in the community and rated their quality of lives higher than those of the general population. And none of them would want to pursue MAID or end their lives now. I just wanted to read actually something from Dr. Chakova, one of the authors of the study. So she describes how it is normal to consider suicide after having a spinal cord injury, and that many patients describe an adjusting period with changing back to how they view themselves that takes about 2 years. Again, and the 90 days is just not sufficient. They said if MAID was legal back then, that they probably would have chosen MAID, but in retrospect are happy that they had time to adjust and are no longer suicidal. Dr. Karen Ethans, the other co-author in the study, said that many doctors who work in the emergency room settings and intensive care settings can have a profound impact on patients after an acute injury when they're most vulnerable. In her experience, these doctors don't often have an informed idea about the lives of people with disabilities. Many of these acute care doctors have made patients feel like their lives are over when they come in with a devastating injury. But that how, as we've said, that most people with this type of injury, having gone through rehabilitation and integration back into the community, rate their quality of life and happiness is quite high, even higher than the general population. So she was concerned that being offered death in that early period, when they're at the most vulnerable to suicidal ideation, especially around the 90-day mark, which is what the MAID legislation requires, is a failure to understand the medical evidence around injury and recovery. And we see definite reports in the medical literature about how physicians do perceive disability. They have misperceptions, actually, of that people living with disabilities have a low quality of life. And does that provide any influence on people being offered MAID at a time when they're most vulnerable? Definitely, persons with disability are worried about that, and we'll talk about that next. The United Nations Special Rapporteur on the Rights of Persons with Disabilities has also expressed concern that expanding access to medical assistance in dying based on disability as a criterion risks reinforcing ableist and ageist assumptions about the value or quality of life of persons with disabilities and older persons with or without disabilities. We know that vulnerable patients have requested medical assistance in dying in Canada due to lack of access to care, cost for their care, and even fear of COVID. I won't go into detail just for the sake of time on all. These are 4 examples that are easy to find in the public media, but the one on the left is Archie Rowland, a person with ALS. He was very happy living in long-term care, but then got transferred without his consent to a facility that didn't have adequately trained staff to meet his needs. and felt quite demoralized, and so requested MAID and received it. The second one is Ray Bourboneau, who was living in a long-term care facility as well, and didn't have adequate air conditioning, and because of the hot temperatures had to leave his door open, and then people would wander in and out of his room, and he felt that it was just a very difficult place to live without any privacy. So he got MAID. The third one is Arlene Rainsborough, who wrote to the Prime Minister saying that she wanted to get MAID to avoid going to a nursing home. And she said, "It isn't depression that makes me want to die. It's the fear of living with inhumane, overcrowded conditions, loneliness, and the lack of hope." She said that the homes she can afford are worse than living on the street or living at all. And the last one on the right there is Nancy Russell, who you may remember from last year. She was described in CTV News as a spry 90-year-old, and she requested and received MAID in order to avoid another COVID lockdown at her nursing home because of the social isolation that had happened during her first lockdown that she just found unbearable. So we see examples of vulnerable patients feeling that they have no other choice but to request MAID. We also see patients who are perceived by healthcare workers as having poor quality of life and are suggested that they get MAID when they're not asking for it. So this is a bit of a bit different. And what the persons with disabilities Roger Foley, actually the person on the right side, he himself presented to the parliamentary process through C7 and told his story firsthand. But that these offers of MAID are perceived as confirmation that society prioritizes ending their lives rather than providing the adequate support and care they need to live. And because of systemic discrimination and ableism, they already feel like a burden to society. So this is not my words, these are the voices of those living with disabilities who are telling us this is their fear and experience. I thought this was a very poignant cartoon that was actually shared again during the C7 discourse, maybe in February, I think this year, by the disability advocacy community. And it just speaks to their concern about suicide prevention versus assisted suicide, and the ramp being made for a quicker access to ending their lives than to help them live. Try to wrap up in the next few minutes so we have time for questions. What other impacts of Bill C7 are we concerned about and seeing? So one thing that I've actually written on in the reference to the paper that came out in February is down below, that I wrote with two law professors who are renowned for their work in law, healthcare law and end-of-life care law, is that the way C7 is worded, and it's about the concept of informed consent. A person needs only to be informed of their options. So told you could have this type of care, you could have an antidepressant, you could see a counselor for your depression. You just have to be told what the treatment options are. There is no requirement that those options are readily available, accessible, or even tried. And this makes Canada the only country in the world that has this requirement. So this allowance, sorry. There are two other countries in the world who allow euthanasia outside of the end of life context. So people who aren't close to the end of their life, and they require all other options for care to have been tried and exhausted first, and euthanasia is only provided as a last resort. But the way that the Canadian legislation is worded, a person could actually choose to become dead as a first-line medical treatment because there's no requirement to have tried and failed other options for care. And so there's lots more we could talk about that, but in the interest of time, I just want to relate it to conscience because there is no protection outside of the province of Manitoba, who has some legislation for conscience, that the rest of the country has no system in place that for physicians who don't want to facilitate or participate MAID indirectly, meaning like do the referral, set someone up, pass, which is a form of facilitation, and for some people it's a form of participation. There's no requirement that you give the direct lethal injection, of course, but for many people, this act of facilitating something that might not be in the person's best interest is problematic. And there's no protections built into the legislation to prevent doctors from being forced. And in fact, some of the colleges, including Ontario, you could face disciplinary action if you don't. And there are certainly institutional and organizational policies that require doctors to participate as well through calling and getting the MAID provider in, doing like an effective referral, and other things that have to facilitate MAID. And so what we need to talk about is this is bigger than just religion. Up until now, that voice of we don't want to be participating in MAID has been kind of put on the margins and accused of being out of the voice of religion. But it's actually many more physicians who will feel it's not their role as a physician when they know that there are standards of medical care that can help a person's underlying condition that's causing suffering that haven't even been tried. So imagine, you're a rheumatologist and you know you have something that can help this person's rheumatoid arthritis, but you're just there to tell them what the options are, and then they say, no, I don't want that, but I want you to provide MAID, and then you're responsible for finding the MAID person and making sure they get hooked up, even though you know there are things that you can do to help. I would say that everyone has a line in the sand of what they feel morally or ethically uncomfortable with. Everyone's line differs. And so there's definitely a range of comfort around how much you will participate or not participate in MAID, but that indeed everyone does have a line. And at some point, because of the looseness and the permissiveness of this new legislation, everyone practicing in healthcare is going to be impacted by this. And I give palliative care as an example because my concerns about MAID relate to my core philosophy as a palliative care physician, that's not part of what we do in palliative care. I don't hasten death. And so if I know I have something that I can help a person with, that they have needs around their pain that haven't been met, or anxiety about what death might be like, but I'm not allowed to be able to provide that care, but then I'm required to facilitate their death, I think there's a lot of actually moral distress about that, which is a perfect segue because that's what we were going to talk about. So I I know a lot of physicians who are struggling, and I think we're not really good about talking about the impacts of the new MAID legislation, especially because it's still unfolding. I think for many people, they don't quite haven't quite seen that this could be a first line treatment and lived that yet. But those of us who have been on the front lines, like palliative care physicians, have been living it on a daily basis for the last number of years. And I think you guys know probably better than me about moral distress, and that it's that pain or anguish that results from knowing the right thing to do, but you're prevented from doing it because of the systems or because of a choice that a patient might make. And so I think we need to talk about this, how it's impacting our teams, that we could have a person before who has an untreated depression and a chronic condition like fibromyalgia, and none of those treatments have been addressed. They know what their options are, and they still want MAID, and you're required then to facilitate that. What does that do to us in terms of our professional vocation as physicians or clinicians? What does that do to us, knowing, as on a personal level, knowing that that might be not in line with our moral or ethical values? And so we could spend a whole talk, I think, just talking about how this builds up over time, the concept of moral residue, but really it does lead to burnout. And I know individuals who are burnt out through their work in palliative care because of this type of moral distress that we're living. I won't go through this in detail. I think you all know better than me, again, like signs and symptoms of what moral distress looks like. But one thing to highlight is that it can lead to team dysfunction. Moral distress impacts our teams. And so our healthcare teams, we really need to pay attention to how we're talking and supporting one another, and not just normalize that, MAID is just a thing we do. Like, it's very challenging on a moral and ethical and professional lens around our role as clinicians. Um, so how do we, and this is a question I think for you as well, to inform me, like, how do we stay present and accompany a person when we disagree or feel something that they're choosing is not in their best interest? In this case, it could be not even in line with the standard of like medical practice, that they might not have informed consent. And how do we address it within our teams? And then I want to just end with this concept. And again, I think like we really could spend a whole hour talking about disenfranchised grief as it pertains to patients and families. But I want to think of us to think about it in terms of how does it pertain to ourselves and our teams, because disenfranchised grief, as again, you know better than me, is it's really grief that's not able to be acknowledged because it's not validated by social or public norms. It could be grieving at work, but it could also be grief because of work. And it can contribute to professional burnout. And I would say that medical assistants in dying Canada in the public realm, and we saw this in the vast media shift over the last few years, has really romanticized MAID as the solution to any type of human suffering. It's pictured as the most dignified death. It's promoted as a legal right. We have recent examples in the paper of couples who are getting made together and they have this beautiful death together. And so there's this sense that this is, if we have concerns about it, that we're just not getting with the program. If we're not championing MAID, we're seen as being against it, even if it's just that we have discomfort and distress. It's not necessarily that someone is against it under certain circumstances. And people who do speak up, and I certainly have lived this, about concerns and impacts on vulnerable people who might otherwise have chosen something different, are kind of marginalized and vilified, that you're blocking people's rights and autonomy and you're not respecting their choices. And so how do you speak up about your concerns about the change in the nature of your work, the grief over patients, but also the grief over the loss of your work and ability to work in a way that you have found meaningful and went into as a vocation? If we can't speak about it with each other, then I think that's promoting, because of the culture we're in, this disenfranchised grief. And I think that's also contributing to the burnout we're seeing in healthcare professionals. So anyway, I know there's lots we could talk about, but I want to end there and just some concepts to bring up around this new challenging landscape that we're living in. Thanks. So I have some time for questions and discussion.
I have to go shortly because I have a client, but I just wanted to say thank you for such a thoughtful presentation. You know, it's true the media is glamorizing it. And also a lot of the concerns that you've brought up are things that I've thought about, to the point where I'm probably not the only one in the room that wonders if there really isn't an agenda to save some healthcare dollars by making access difficult. I've had plenty of anecdotal moments where I've heard about a doctor trotting out the MAID option fairly glibly, like, oh, you don't want to suffer, so you know, so did you know MAID is an option? And there is the ableist risk, because somebody who is on the able side of a disability doesn't know how much quality of life there actually is on the other side of a disability. And it's there's a lot of peer pressure. You know, one gets concerned about economic pressure. Like, what is wrong with the system where there's examples that you brought up, the person didn't have access to palliative care or access to disability mobility devices? What is wrong with our system where we make it so hard to live?
Thank you, Heather. I share your concerns, and I think the disability community has been very vocal about that. And I brought up the Canada Health Act because there's a strong effort put in, even by the two national palliative care organizations, as well as the disability rights advocates during this legislative process. They could have made home care and palliative care and disability supports essential services under the Canada Health Care Act, as they have already done MAID. And so it certainly seems that there's some political agenda, and I don't know. I mean, there are studies published around the cost savings of medical assistance in dying. We don't have time to go into it today, but is quite significant. And so you do wonder if sometimes it might become an easier solution than putting in the supports necessary to help people live well. Mary.
Hello there. I had a question about the degree of disability. And I wonder if you could flip back to your slide or refer to it. Under the list of possible disabilities, I think it said the disability had to be like end stage or some degree was mentioned, I believe. Oh, I can't hear you, sorry.
Oops, sorry, I was on mute. That was weird. I'm just going to read it because it'll be easier than sharing my slide. So any impairment, physical, mental, intellectual, cognitive, communication, or sensory, or a functional limitation, whether permanent, temporary, or episodic in nature, that hinders a person's full and equal participation in society. That's the definition of disability.
Okay, so there's no definition of, there's no mention of degree.
No, that's subjective because it's only you as an individual person. This is what the legislation says. Know what your suffering is, and that so there's no degrees put around it, the same as with any of the chronic illnesses as well.
Mm-hmm. Well, I'm a retired pediatrician. I'm certainly glad that retirement came at a time before MAID was in place, but now I'm doing some volunteer work with palliative care. It's really overwhelming what you've been talking about. Thank you very much.
Any other questions? I would love to hear some of your thoughts on moral distress and, oh, I see hands. Where's Robert? I need your help, Robert. Bernadette?
I'm trying.
I'm terrible with the raise hand things. Bernadette has her hand up. Okay.
I just have sort of want a clarification. I have a family member, a recent graduate, nursing graduate, but the feeling that I get is they consider palliative care and MAID is underneath palliative care. And that in the hospital, a palliative care team, they have to refer to MAID as one of the solutions for a dying person.
Yeah, so that I actually will send maybe through Robert, I'll send a link. So we did a whole series of talks through the De Weber Institute in February. They did I'm not sure if you're familiar with the De Weber Institute of Bioethics and Social Research. Yeah, so they did a whole series of emergency lecture series on palliative care and Bill C7.
Okay.
I gave a whole talk there that's available online, but the other talks were also very good. That went through all of that. So what is the impact of the euphemistic language and the confusion and the misrepresentation of, even if you recognize like this Canadian Medical Association has a distinct nature of MAID and palliative care, by continuing to refer to it as end of life care, it promotes this misunderstanding of what it is. And it actually has caused confusion and harm in the sense of, we have documented cases of people who refuse palliative care because they think it's MAID. And then patients who have requested palliative care and the MAID team gets sent. And so that there are many examples of that as well. And unfortunately, early on, because there is just this notion that it was like end of life care, even though reasonably foreseeable death could be many years, right? Provincial governments lumped the MAID service under palliative care because they're like, well, it's part of end of life care. And so even in some places, it diluted the funding for palliative care, because now, for example, in some places in Ontario, the hospice palliative care nurse practitioners who hadn't had necessarily any training in palliative care, but were doing palliative care, they were said, oh, this is part of your mandate now. Without knowing any better, they started doing it. And so then you have less available palliative care resources, because now MAID is being brought in to palliative care. That was early on, and we've since addressed that. But those people still continue to provide MAID with their palliative care funding. So there are many issues, but I encourage you to watch the De Weber Institute talks. Very good series. Yeah, I can send a link.
I find it very hard talking about palliative care to people because they have that attitude and that's their understanding. So I think our language really has to be explained quite well when we're talking about palliative care. And because we're asked to fight for palliative care, but then if people have this misconception with MAID, it's very challenging as well.
Yes, exactly. It's something we have to continue. And we've worked really hard on a national level.
Yeah.
But again, the culture has been, when we're advocating for the distinct nature and understanding, we're seen as being opposing MAID, which is not at all. We're trying to clarify and be pro palliative care. So it's a
Yes.
very interesting culture that we're in. But yes,
Ugh.
I think getting rid of the euphemistic language is a huge thing, and we tried to get the government to do that. It's not medical assistance in dying. That's what we do in palliative care every day. But this is a life-ending procedure. It's not even end-of-life care now, because it's not people who are anywhere near the end of their lives in many situations. So, Greg, I think you have your hand up.
Yes, thank you. First of all, thank you for your presentation. Wonderful. So I'm just wondering, so across the different verticals of the healthcare professions, have there been studies done on the actual professionals and their response to this? So are there percentages of for and against, for instance, across the different things? So whether it be general practitioner versus nurses in the hospital versus surgeons versus, kind of a breakdown of each of those. And if not, I guess I wonder why they wouldn't go to the experts to get their feedback on this.
Yeah, so I haven't seen any studies like that. I can say our National Specialty Society of Palliative Care Physicians has done that. But I think there is also a difference between people informed about the legislation and what they're supporting, right? So there might, and there are people who are supportive of medical assistance in dying under the old regime of C14. So for people who have a reasonably foreseeable death, including MAID assessors and providers who've said this themselves, that do not feel comfortable under the new legislation when people could have a treatable illness and not receive any treatment. And so I think that until people actually understand what it is that we're talking about, that would be really hard to do that type of survey. But I do agree that there needs to be more education first and understanding developed, and then that type of study. Thanks. It says Gary, but I'm assuming you're not, it's not Gary.
Was that me?
There's a lady that has her hand up. It says Gary Hudson, but you're on mute.
Sorry, it's Mary Jean, but
hi.
he set it up for me, so it always comes up Gary. I was just going to say, when you talked about moral distress, so I was a nurse up until last year, and I always worried about the ethical stuff going on in the hospital. I worked in the operating room, so I wouldn't have a problem, with MAID, but I did with abortion. And it was always like every day, it was a worry that they were going to, ask me to do something. And people would say, but it's not your decision. You're not doing it. The doctor's doing it. And so my response to that, which changed on some people's minds, was, okay, I want my husband dead, but I don't want to pull the trigger. But I bought you the gun and asked you to do it. Would I go to jail? Well, of course you'd go to jail. And I said, well, it's the same thing. It's still, my moral conscience doesn't agree with it. And so how can you see that there's any difference between that? And they didn't when I explained it that way. And then you talked about, moral conscience again. I mean, when I retired last year, I let my license go because I did want to do palliative hospice care, but I wanted to do it as a volunteer, so nobody could ever ask me to participate in anything. So I let my license go, so there is real repercussions for people who, maybe didn't want to let their license go. I mean, I could be in those COVID clinics right now making big money for nothing, but it's not worth it.
So I know a number of palliative care physicians who retired earlier or actually left palliative care practice because of the moral distress and burnout that they've been experiencing navigating this landscape over the past few years.
Yeah.
So
Yeah.
it is significant. But I think that, the health system needs to be responsible for being able to support individual clinicians in being still able to do their work and still provide access to this procedure that Canadians want, and that the courts and the legal system, I didn't go into this, have decided is part of medicine.
Yeah.
So the standards around MAID are not evidence-based medical standards. They were mandated by legislation and the courts, which is not the way usually healthcare and medicine evolves. We do, research and evidence-based harms and analysis, and we develop our protocols based on the evidence. In this case, our protocols are based on legislation, and that it was mandated by the Supreme Court that it would be medicine that provided it.
Right.
So it's a tricky place to be in, but it's a health system responsibility to create, or the legislators to create systems that provide access and allow those people who want to have it, but support those of us who don't necessarily want to directly provide it, to be able to continue to do our jobs without,
Yeah.
So yeah.
Yeah, and the other thing I was just going to say about the wording, I remember a discussion I had with two individuals that worked at the hospital. They were not nurses, but they were in direct contact with us all the time. And we were talking about MAID, and the one girl was saying, well, I'd have that for my mother. And I said, well, oh my God, why? And we got into a big discussion about it. And then, and I just couldn't believe that this person would think that that was okay. And finally, at the end of the discussion, I said, well, you know what? I said, I'll never kill you. I'll look after you the best I can till the end of my time. And she said, what? Kill me? I don't want to die. And I said, but that's what it is. Oh my God, she said, I would have killed my mother because I would have said yes. She had no idea that it was euthanasia. And I thought, she works in the hospital, so for the people out of the hospital, I really understand how they get it mixed up, so I just always say euthanasia. I never say MAID, but.
Yeah, I think the language is definitely problematic. And I mean, I routinely still now 5 years out, see patients and also other conversations, as you said, with healthcare professionals who do not understand what MAID is. So that's why I actually intentionally started with the definition that it's a lethal dose of drug to intentionally end someone's life. And some people want that, but there are many people who don't understand that's what they're asking for. And so the examples like John now that Dr. Miyazaki gave, like it used to be in palliative care when people are angry, grieving, lamenting, they're faced with this terrible diagnosis or something, new has changed their lives. They would express, oh, I'd rather just be dead, and now, so that desire to die is part of normal grief and coming to terms with a diagnosis. But now people say, I just want the injection, or I want MAID. And I think we need to do a really robust, at least qualitative or mixed method study to really look at, like, how many of those people know what they're asking for, and is it just a new expression of lament and grief that now is just being framed in a new cultural context because we have this legal procedure, but they might not fully understand, and that's not necessarily what they want. Like they actually want their pain controlled, like it's like palliative care 101, right? Like they actually just want to be able to focus on living, right? So medical assistance in living.
Assistance, period.
Yeah.
Not the other part. Yeah.
I think lots of work for us to do.
Yeah, thanks.
Any other questions? Thanks for staying on a few minutes later. It's a good discussion.
I'm curious about the relationship between palliative care and hospice. Hospices seem to be flourishing. They're popping up across Ontario, certainly, in small communities even. We're still working on getting one here in Kingston, a residential hospice. But if that's expanding, is that helping to meet the need, let's say, in rural communities? And is there a similar expansion of palliative care funding and programs? I'm just alarmed with the statistic you provided that access to palliative care in Canada is less than 30%. Where do you see this going in terms of enhancing, improving palliative care in possible relationship with hospice?
Yeah, so good question. Thanks, Robert. So hospice care is part of palliative care. It's one part of the work we do to provide care at the end of life. And so I see them as the same. Been lobbying at the national level, and one of the problems is that if the government, the federal government has given some money to provinces for home care, including palliative care, but because it's not deemed an essential service, there's no accountability for standards, and that the money actually goes into palliative care. So while we may have gotten, X millions of dollars that came to Ontario, it mostly went into home care, and there's no accountability around that. So I'm hoping that we have a new, it's called Compassionate Care Act. So it's a legislation that was approved in December 2020 through the provincial legislature. It's just to set the standards for palliative care in Ontario. And I'm hoping that through that, we can have a really robust process of like looking at the population needs, how many beds we need, and really get that funding earmarked, not just to go in the big basket of home care. But anyway, there's lots of issues. So I don't think we've seen actually, although we're hoping to get the Hospice Kingston in the next couple of years, that's all been raised mostly through private donations. There's not been a big increase in funding for palliative care at a national or provincial level. Yet, as I said, there's a discrepancy in the access to MAID. So I think that it's going to take a public outcry, and we really tried hard, all of us through the C7, we tried to really raise attention that this is a big problem. And it didn't seem to have any political clout. So without political clout, I don't think it's going to happen. So I think we're going to, in our local communities, really have to look at more grassroots initiatives for how we care for one another. And I think the role for volunteers is really important. Spiritual health is very important, and look at how we care for one another in smaller community settings.
Thank you. Any other questions before we wrap up?
Hi, this is Janita. I don't have a question, but I do want to say, as somebody that has supported people when they are dying this way, and have seen this from many different perspectives and angles, and worked in it, and it's so complicated, and it's certainly influencing our society around dying and death. And I mean, we already have so much fear around dying. There's so much death phobia. There's so much done to just push it away and not to include it in a good way as part of life. But saying all of that, what I want to say is that I just want to thank you for your work and for this really excellent presentation, and for the courage that you have and the energy that you put into your courage to speak up about all these really complicated aspects of this, and to keep that in the forefront and part of the picture and part of the conversation. It's so important. So thank you very much.
Thanks, Janita. That means a lot. I think the most important thing is to have the dialogue, right? It's and be open to learning from each other.
Yeah, absolutely.
Yeah. Thanks. I see someone with their hand up. It's a phone number, so I'm sorry I don't know who you are. 710-436-3510. Any other? Maybe it was a raised hand by accident.
I unmuted that person. If you can go ahead. No? Okay.
Oh, they said there's a question in the chat. Oh, okay. He wants to request it's a big topic. Like, I wasn't sure how to focus my time, because I think understanding the evolution of the legislation is important, but then there's so much we need to talk about in terms of moral distress and disenfranchised grief, and around our role as healthcare professionals accompanying people. How do we take care of one another? Like, I wish we had time for just a whole, so maybe one of you can do a talk on that and I can attend and learn from you. But I hopefully at least opened up some, conversations for us to continue to have together.
Wonderful. Thank you so much, Dr. Herx. It's It's a very helpful presentation and helped clarify many things. And it's just terrific to have you on with us and to engage with us. And thank you very much. Just one final check. Any last questions or comments among participants? Okay, so thank you again. And thank you for letting us record the session. I will be sending out the link for the recording. And
Thanks for having me. I appreciate it.
thank you. Bye, everyone.
Take care.